Right, welcome back to chapter 17, looking at psychological disorders. We're going to briefly talk about schizophrenia. So, schizophrenia is a serious psychological disorder, and it's marked by some of the following symptoms: by delusions, hallucinations, loss of contact with reality, inappropriate affect, disorganized speech, social withdrawal, and deterioration of adaptive behavior. Now, schizophrenia is the most chronic and debilitating of all disorders, and it doesn't discriminate. It affects men and women equally, occurs in similar rates across cultures, and affects at any one point in time approximately about 350,000 people in Canada. Now, the onset of schizophrenia is usually between the ages of 16 and 30, and it's very rarely after the age of 45 and very rarely ever seen in children. Now, when we're talking about the symptoms of schizophrenia, we're talking about positive symptoms, negative symptoms, and cognitive symptoms. Now, not all patients experience all of them, but amongst these symptoms, here's kind of how it kind of looks. So, positive symptoms are abnormal behaviors or experiences. So, positive, you're adding something on. Okay. Negative symptoms is a loss or deterioration of thoughts and behaviors. Negative, you're taking something away. All right. Now, negative symptoms in general are a predictor of poorer functioning. And then finally, we have the cognitive symptoms, and these are changes in cognitive processes. Now, one of the other things, too, that we kind of have to mention is the word psychosis. So this is a word that gets tossed around quite a bit, and oftentimes it seems that people don't know what they mean when they're using it. Psychosis, though, is a psychological condition that's characterized by the loss of contact with reality. Okay? So, for example, someone experiencing schizophrenia may have a psychotic episode. So that would mean that they have lost contact with reality for that period of time. Now, here is a very handy-dandy little chart about the symptoms of schizophrenia. So if we're looking at the positive symptoms, so we're looking at the things that are added on. We have hallucinations or delusions, derailment, grossly disorganized behavior, inappropriate affect, movement disorders. On the negative side, we have things taken away. So there's social withdrawal, flat affect, lack of pleasure, apathy and loss of motivation, distorted sense of time, lack of goal-oriented activity, limited speech, poor hygiene. Cognitive symptoms, you see poor executive control, trouble focusing, working memory, and then poor problem-solving abilities. Let's talk a little bit about some of these symptoms. So what are hallucinations? Hallucinations are imaginary sensations that occur in the absence of a real stimulus, or which are gross distortions of a real actual stimulus. Most patients, if they're going to experience a hallucination, it's likely going to be an auditory hallucination, so them hearing a voice. However, there's that 25% of people who also experience visual hallucinations. These are less common and frequently involve seeing God or the devil. Now, we also talk about delusions. So delusions are false beliefs that are not commonly shared by others, either in your own culture, and these beliefs are maintained even though they are out of touch with reality. And so if you challenge a delusional belief, you're not going to get very, very far. You can show all the kinds of contradictory evidence. It's going to not do you any good. Now, one of the kind of subtypes of delusions are delusions of grandeur. And so that's where people believe that they're important, they're famous, they're powerful. Maybe they become convinced that there's someone else, such as the president or their God, or they have some kind of special talent or ability. You can also, though, get people with delusions of persecution, and they believe that a person or a group seeks to harm them, and there's a good chance that they will become violent because they actually feel threatened to their person. Some other positive symptoms that we see are things like disorganized thinking, or what we call derailment, and that's when you're shifting from one subject to another and it doesn't follow any kind of line of thought or conclusion, and you make these tangential associations. So to give you an example, you can kind of check this out, but I think someone's infiltrated my copies of the cases. We've got to case the joint. I don't believe in joints, but they do hold your body together. Okay? So that would be an example of disorganized thinking or derailment. You can also get very disorganized speech, so that's when you're switching between topics randomly, connecting unrelated content, or just kind of talking in an incoherent or kind of what we'd call like a word salad kind of way. Just putting words out there and none of them actually make any sense. You also might see some disorganized or abnormal motor behavior, so either muscle rigidity, purposeless movements, bizarre postures, or catatonia. So catatonia is where you kind of completely freeze in a state and stay there for an indefinite period of time. You also see some inappropriate affect, so laughing when a person should be sad, or crying randomly or unexpectedly, where emotions don't match either the topic that's being talked about or the situation. All right, so really not reading the room well. Now, in addition to positive symptoms, there are also negative symptoms. Most of the negative symptoms involve things like just stopping doing some things. So social withdrawal, poor hygiene and grooming, poor problem solving abilities, a distorted sense of time, having flat affect, a general decrease in anything that we would consider a self-motivated activity. So something that we would like to do. Now, the cognitive symptoms may kind of be difficult for outsiders to recognize, but they also impair functioning. And so that would be, for example, difficulty comprehending information and using it to make decisions. So that's kind of that lack of executive control, difficulty maintaining focus and attention, problems with working memory. All of these things are are big kind of challenges. Now, when we're talking about how do we explain schizophrenia, look, there's no real single cause of schizophrenia. There are some important factors, but I'm going to show you that it's not just a very clear kind of direct path that, because of A and B, we now get to C. There's a very complex kind of pathway here. Now, take a look at this graph. Identical twins, right, share 100% of their DNA, okay? So if you have schizophrenia, the likelihood, the risk of developing schizophrenia in your identical twin would be 48%, okay? So about 1 in 2 chances that if one has schizophrenia, the other will have schizophrenia. That is high, right? Now, if you're fraternal twins, where you're sharing, still sharing kind of a higher degree of genetic, well, again, 100% genetic material. If you're fraternal twins, it's only about 17%. Okay, if you, as a parent, your child has a 13% risk of developing schizophrenia. If you have schizophrenia, siblings 9%, and so forth. It kind of goes down all the way to the general population, which the risk of developing schizophrenia is about 1%. Okay, so obviously this is a highly heritable disorder. Okay. But there are also some important environmental causes. Okay, so again, remember, just because you have a genetic predisposition, it does not mean that this is the actual conclusion or this is the outcome. So, for example, even if a person has an identical twin of schizophrenia, that person still has less than a 50% chance of developing. And over 60% of all schizophrenic people have no first or second degree relatives with schizophrenia. So that kind of messes with things a bit, doesn't it? So how do we explain it? Well, some neuroimaging studies have found some differences in brain structure between people with and without schizophrenia. So for example, the cerebral ventricles, which are fluid-filled spaces in the brain, tend to be enlarged in people with schizophrenia. We also have exhibited that there's a overall loss of neurons in the cerebral cortex compared to people without schizophrenia, and a decreased level of neuronal connections in the prefrontal cortex. We see less neural activity in the frontal and temporal lobes, and a decreased size of the temporal lobe. In addition, we also see abnormalities in their auditory cortex and in Broca's area and Wernicke's area, which are connected to the auditory cortex. So if you're like, man, we didn't cover any of this stuff, John, that's okay. Come check it out in Psych 120. We can talk about it there. Now, all right, so we know that there are some of these structural abnormalities. Are there some other factors? Well, yes, there are. Many researchers believe that schizophrenia is caused in part by excess dopamine. And this is supported by the fact that the drugs that used to treat schizophrenia tend to be effective, in targeting dopamine. But a lot of recent evidence has also suggested that the role of neurotransmitters in schizophrenia is more complicated than what once believed. So, for example, are neurotransmitters the cause of schizophrenia, or are they the result of schizophrenia. So, for example, is excess dopamine the cause of schizophrenia, or is it the result of just of having schizophrenia that all of a sudden there is excess dopamine um, available in the brain? So, we're still trying to figure that out. We do know, though, that there are some important disruptions to normal brain development. So, for example, if in situations of malnutrition, rates of schizophrenia rise. Um, Maternal flu virus during the first 4 months of the prenatal period increases the risk of schizophrenia. Injury to the brain or oxygen deprivation, and maternal stress during pregnancy, all of these factors increase the likelihood of schizophrenia because all of these factors impact normal brain development. We also know that there's something going on there with synaptic pruning. So we know that there are less neuronal connections. And we know that within the brain there are several times that the brain goes through these synaptic pruning time periods. But one of the kind of theories is that the brain of people with schizophrenia, it prunes too aggressively during adolescence. This then leads to significant loss in sensory and motor regions. Levels of stress. This plays another important factor, and it plays a factor in the development of pretty much every psychological disorder. It is possible that people who develop schizophrenia are more vulnerable to stress in general. All right. We also know that high levels of expressed emotion um, are very influential in the development, maintenance, and in recovery from schizophrenia. Now, here is one of the things, and I kind of alluded to this in a previous video, but schizophrenia is one of these very feared um, disorders. And a lot of the fear and stigma surrounding schizophrenia is that people with schizophrenia are incredibly violent and that leads to violent offenses. And anytime that you talk about schizophrenia and violent offenses, if you're a Canadian, you have to think about the Vince Lee story. So on July 30th, 2008, Vince Lee decapitated and then cannibalized a fellow passenger on a Greyhound bus. All right. Now, in 2009, he was found not criminally responsible due to mental disorder, or an NCRMD designation, and he was sent to a psychiatric facility in 2009. Now, the big question that always comes down to, and I love having this discussion in class, so this is going to be not as satisfying for me, but does the punishment fit the crime? Now, people have very strong opinions about mental disorders being found not criminally responsible, and people with schizophrenia being allowed to be set free into our communities. Because here's the reality. Vince Lee is no longer under psychiatric care in the sense of being in a psychiatric facility. He's actually living a fairly normal life in, I don't know exactly where, but he's living a fairly normal life. He's out and about, and he's trying to kind of pick up the pieces of his life and live well. So here's the question. Is this guy a danger to be out on our streets right now? Well, here's some important facts about NCR designations. So here's the first thing. So many people argue and say, wow, it's so easy to just get a not criminally responsible thing in the courts. Well, here's the thing. Out of all adult court cases in Canada, NCR court cases represent less than 1% of all adult court cases heard. Okay? Most NCR crimes that are committed are not violent and are also not directed towards strangers. So here's the thing. We spend an inordinate amount of time being worried about strangers being out there killing us. The reality is that you are more likely to be killed by someone that you know and love than what you are to be killed by an absolute stranger. Okay? Now that is a terrifying thought. Okay? But here's the thing about NCR is that most NCR crimes are actually not violent, and they're not directed towards strangers. They're directed towards people that the perpetrator knows very well. Another little piece of evidence here is the rate of reoffending for someone with an NCR designation versus a person out of the general offender population is significantly different. People with an NCR designation, and when I'm saying rate of reoffending, we're talking any kind of crime. All right, so this is anything from, failing to appear. This is anything from stealing. Any kind of crime. Okay, is 17%. Whereas for someone from the general offender population, it's 34%. Okay, And the rate of serious violent reoffense for NCR is 0.6%. Okay? So we've got to kind of take these things into consideration, because if you're the serious violent reoffense rate for the general population is somewhere in that, oh man, I'm gonna totally butcher this, but if I'm trying to remember right, it's about in that 10 to 15%. Okay, so that's pretty high. Okay, but anyways, I'm gonna check that out, because now that I've said that, I'm kind of curious to think that through a little bit. The other thing too that's important to note about an NCR defense is, let's say that I decide to go to court, and you know I say, okay, well, I'm pleading not criminally responsible due to mental disorder. Well, here's one of the things. In most cases in the court, it's innocent until proven guilty. In the case of an NCR designation, though, the person, the perpetrator, the defendant that is using this claim, has to provide all the evidence to demonstrate why their claim should actually go through. And this is a hard thing, because in order to actually demonstrate that you're not criminally responsible due to mental disorder is a pretty significant task. It's not something where you just get a psychiatrist or psychologist to write you a note and then you're like, oh yeah, no, it's all good to go. NCR. It's actually a very, very challenging. Out of all of the defenses to mount, not the easiest. All right. Finally, here's the important thing. Most NCR crimes, well, NCR crimes in general, are likely preventable. All right? 72% of all offenders, of all persons who have had a NCR offense, had at least one psychiatric hospitalization prior to that. Okay? So it's important for us to consider that perhaps what we should spend more time in is, how do we then help people with these psychiatric hospitalizations to do better after release, rather than kind of responding to these things after the fact. Now, I'm really curious to hear your thoughts about NCR stuff. Looking forward to seeing what's happening in the chat with this, so please throw some good thoughts in there. And we're going to be talking about personality disorders next.